Hi, my name is Mohammed Raja, and I'm an advanced digital service practitioner here serving in National Health Service. We have got Tawseef, which is a consultant podiatrist, consultant physio, Amir. That's our privilege to having both of them here today. So the main aim is to deliver and just expose you with the contemporary research, the contemporary physio skills in ultrasound, especially in shoulder and knee. We've been doing ultrasound for some time. I passed out in 2018, and Amir, he was in 2016. He graduated from Essex University. Since he's been practicing and in fact teaching and mentoring people here. So the main, to be honest, aim or wish to deliver or provide insight of ultrasound to our Pakistani students in Pakistan. Whatever we have learned here, whatever we understand in this environment, wanted to expose our next generation and leave that legacy to them, to learn more and think about broader perspective rather than just the physio's classical physio treatment. So without further ado, I would request our senior and consultant Amir Sattar to come and join us and give us further demo and explain us about short planning. Would you like to say something?
Yeah, I think thank you very much for everything you guys have said about the ultrasound and everything. But I think it's time to ask Yasir to come in and say a few words before we start the proper ultrasound scan now. Yasir, can you speak a few words and then I start the ultrasound scan, all right?
Thank you very much. Assalamu alaikum, all of you. I would like to welcome all participants and I would like to thank to all facilitators for arranging this webinar for our students and graduates. I would like to commend the efforts of Sports and Musculoskeletal Physical Therapy Society of Pakistan to support physical therapy students and graduates in this region, helping them their skills, to enhance their skills and promote the best evidence-based practice in physical therapy. And again, I would like to thank to Mr. Amir Safdar, who arranged this informative webinar for our students and graduates to learn this new skill so that they can incorporate this diagnostic modality in their practice and to promote their practice and to get better results of their therapeutic interventions. Thank you very much, all of you, all the facilitators. Once again, the time is running out. I would request the facilitators to start the session.
I hope you would like it, and let me start it then. All right. So,
what do you want them to see?
We want them to see the shoulder ultrasound, all right? The shoulder ultrasound, what we want is to look at the rotator cuff tendon and the biceps tendon and the joint. What you're seeing in the middle here, that's your biceps tendon. That's what your then a pointer is, that's your lesser tuberosity, and this one is your greater tuberosity, and between them is the bicipital groove and your biceps tendon, all right? So we drag the biceps tendon down, we drag the biceps tendon down, and we drag the biceps tendon up, all right? And that's your biceps tendon in the short axis, and then you move your probe and get the same tendon in the long axis. All right, as you can see that while doing that, there is some fluid collected. That's where the fluid is collected in the biceps tendon. So what is happening here with this gentleman? Could we
get somebody to say that they can actually see the arrow and they can see what they're what we're talking about? Because at the moment, from the screen point of view, I can see an image. I'm not sure whether you can see the finer intricacies of the image.
Yeah, so can you please confirm that?
Yes, we can see the arrow on this.
You can see. Is that good enough? Would you like me to take it a little bit more closer?
If it is possible, please take a closer look. But it is visible right now.
All right, that's fine then. Okay.
All right, that's fine. There we go.
Yes, that's right. That's right.
That's right.
Yes.
Okay. So what we're going to look at now, we're going to look at the subscapularis tendon. So if you see this beak-shaped thing, that's your subscapularis tendon. This is your subscapularis tendon right below the deltoid muscle. And you can see that some cortical irregularity underneath it. All right. So this is your subscapularis tendon right under the deltoid muscle. So what we're going to do is that we're going to do the impingement test of the subscapularis. So how are we going to do it? We're going to get this coracoid process. This is your coracoid process here. That bony bit is your coracoid process. This is your deltoid muscle on the top. This is your coracoid process. And this is your subscapularis tendon. So what we're going to do is some internal rotation and external rotation to see if the bursa is bunching under the coracoid process, which is the impingement sign. All right. Okay, can you see that how the subscapularis is internally rotating the humerus, and the bursa is kind of bunching under the coracoid process. So in nutshell, the gentleman that I'm scanning in is having some impingement syndrome. Right? Okay. So we can see the same tendon and the same bunching in the long axis as well. So you can see it's bunching in the long axis as well. So when we take the images of the ultrasound, we take two images of the ultrasound. All right. One in the short axis, one in the long axis. Okay. So moving to the next level, we're going to have a look onto the supraspinatus. So look at the supraspinatus. So this is your supraspinatus tendon. This beak-shaped thing is your supraspinatus tendon, and the gentleman having a tear in the supraspinatus tendon with bursal thickening. So this is subdeltoid subacromial bursa, which is thickened. The normal size of the bursa is 1 mm, but in this case, this is 2.7 mm. So as we've seen in the internal and external rotation of the subscapularis, there was some impingement going on. And then we can see the bursa is thickened because of the impingement, right? On the top of that, the gentleman, let me measure it again, the bursa. And then let me measure the tear. So that's the tear, which I'm measuring now. The black hole in the tendon, that's the tear in the supraspinatus, right? So what normally happens is that this is the long axis of the supraspinatus. We're going to move the probe a little bit, and we get the short axis and see if the tear is a full thickness or the partial thickness. So what I'm looking at is the short axis of the tendon, and I can see the tear is a partial thickness tear, all right? It's an articular side partial thickness tear within the mid portion of the supraspinatus tendon. From there, there. So that's the depth of the tendon, and this is how far it is from the bicipital groove. There's a partial thickness tear in the mid portion of the supraspinatus tendon, and it is almost 16.58 mm away from the bicipital groove. So why we need to understand, what we need to understand that it is important to understand that it is a partial thickness tear, and the size of it, this will help the surgeon. This will help the surgeon to, if they need to repair it, they will have a good idea where the tear is and how big that is. And then it will also help the physios to understand the tear, where the tear is, and formulate the exercise program and the management program for that. All right. Okay? All right. So let's have a look onto the AC joint. So that bit on the top is your AC joint. So this is your acromion, this is your clavicle, and this is the transverse ligament on the top. So this is your AC joint. Normally you can see the gentleman starts to have some degenerative changes in there. If you see that there's an irregularity of the bone here, and that's how the degenerative changes. So means some osteoarthritic changes start to appear in the AC joint. Now from the same position, what we normally do, we also do another impingement test, okay, where this is your acromion. This bone is an acromion, and this is your supraspinatus tendon. So what happens is that we ask the patient to lift the elbow sideway up and see if the bursa is bunching under the acromion, which means that it's an impingement going on. So if you can see that the supraspinatus is appearing, and then as the patient lifts the elbow up, it's disappearing under the acromion. And if it is painful, the impingement test is positive, right? That's what the picture goes. So again, this is your infraspinatus at the back. Yeah. So this beak-shaped tendon here, right on the humerus, the lateral facet of the lateral and the posterior facet of the humerus. This is your infraspinatus coming and attaching on there, right? And then going down further, that's your glenohumeral joint with the labrum. So this is your glenohumeral joint and the capsule of the glenohumeral joint, and this is the labrum at the bottom, right? Talk about the steroid injection in the glenohumeral joint, but steroid kills tendon cells. So at the cost of treating pain, we are aggravating the problem. So let me tell you one thing, glenohumeral joint is a joint. not a tendon, first of all, right? And when we are going into the joint, we are actually going into the joint. We are not treating, we are not going into the tendon. And even if we have to do the injection for the tendon, we don't actually do the injection in the tendon. We do on the tendon, on the top of the tendon in the subacromial subdeltoid bursa. You never go into the tendon, right? The yes, even if we do into the subacromial space, you would still have to be very careful. And that's the beauty of the ultrasound. You actually end up into the bursa. When you're doing the blind injections without the ultrasound, you can end up into the tendon and leave the medicine in the tendon, which can be detrimental for the tendon in the long term. But when you're doing it under the ultrasound, we know we are sitting into the bursa, we're not going into the tendon, we're not touching the tendon, we're not leaving the medicine in the tendon. And then as long as you're leaving the medicine into the bursa, absolutely safe and fine, and the bursa will feed the tendon. Okay, that's the one thing. When we do the PRP, we go into the tendon and we treat the tendon because it's absolutely safe and fine. But when you're talking about the glenohumeral joint, if somebody has a frozen shoulder and a capsular pattern, we don't go into the tendon, we're going into the joint and leaving the medicine right into the joint, which helps the capsule to loosen up and get rid of the capsulitis. So it doesn't affect the tendon at all. I hope that answers the question.
Abdullah says,
Yeah.
Assalamu alaikum, can you tell some keywords that can be used to remember ultrasound values? For example, you said it's black for tear. So I suppose how do we identify the tissues? So if it's a tendon, how will they appear? So if you can,
I think Abdullah, this is a fantastic question, and I was expecting that kind of question from one of the candidates. I would say that you have picked up a very, very good question. So thank you very much once again for picking up such a wonderful question. Now the simple answer is that the ultrasound is a gray scale, all right, which means that black, white, and the gray. So when the fluid is more black, all right, and the bone is white. So the whitish component on the screen is your bone, and the darkest component on the screen is the fluid. All right. So if you want to see any inflammation in the joint, you will be seeing that the black fluid is filled or collected in the joint space. All right. You leave your name and your email address and the city or the organization name, four of those things, in the chat box. If you want us to send you the certificate of completion or attendance, we are happy to send you. All right, but you have to make sure you put your name, your email address, your city, and the organization name. Four of those things. All right, Krishna, can we mention that in the chat box? If anyone of you wants a certificate, please do that, and we will send you the e-certificate on your email address. The second thing is that if you have any question, you can always contact us. So Krishna will share the email address with you. If you have any question, you can always contact us. So thank you very much. Thank you very much for joining us. And then we are more than happy to help you with any question if you may have in the future. Yes, I would like to do the